Okay. So as I said, this view gives us a little bit more information than that lateral view. This is a view called a superior view, right? Or superior-inferior view. That tells us we're looking from above the vertebra. We're looking down on a vertebra, okay? Anterior of the body is at the bottom of the screen, posterior is at the top of the screen. And what's most important to take away from this image, you're going to have to be able to label anatomy, okay? The state puts some emphasis on labeling anatomy. Remember they put like a medium emphasis on labeling anatomy. But so you're going to have to understand, when they point here, right, what is this? Well, it's the pedicle, right? So you're going to have to be able to label the anatomy. But first off, we need to get on the table, what angles do different structures sit at, right? So recall from the last slide that the superior and inferior vertebral notch, right, the depression, that hook, the loop-like depression in the side of the vertebra, allows for peripheral nerves to branch off the spinal cord laterally, and so that sits at a 90-degree, that gap, that notch, sits at a 90-degree angle to the mid-sagittal plane of the body. This is our main plane of the body. We should get most familiar with the mid-sagittal plane, the plane right down the middle of the body, okay? Dividing the body into an equal left and a right. And intervertebral foramina, or the notches that make them, lie at 90 degrees to the mid-sagittal plane. So they're only seen when you put the patient in the lateral projection, as I said a minute ago. The articular facets. The articular facets lie at a different angle than they did in the thoracic spine. Do you guys recall the angle that these articulations were at in the thoracic spine?
30 degrees.
A little bit more.
30 to 50?
It's about a 70-degree angle, 60 to 70. It might change. It changes depending on where you're at in the spine. Like the higher up you go, the greater the angle that they sit at. The further down you are, the lesser the angle. But so, because they change in their appearance. The lower thoracic vertebrae are looking more like lumbar vertebrae, and lumbar vertebrae have this very shallow angle. Okay, so thoracic vertebrae sit at about a 60 to 70 degree angle. That's their articular facets, meaning that you have to rotate the patient. Imagine this being the patient, right? You'd have to rotate that patient in the thoracic spine 60 to 70 degrees until that joint space would be visible, right? In the lumbar spine, it's about 30 to 50 degrees. Less angulation, a shallower angle, the lower you are in the lumbar spine. So lumbar vertebra 5 has a much shallower angle than lumbar vertebra number 1. Lumbar vertebra 1 is closer to 50 degrees, whereas lumbar vertebra 5 is closer to 30 degrees. But on average, roughly speaking, it's about a 45-degree angle here, okay? Which means for the oblique of the lumbar spine, we rotate the patient 45 degrees, okay? Let me see if I can do something here. No, I cannot. That's okay. All right. So, this is our anterior of the patient. This is our posterior. Imagine for a moment that the patient was put into the PA projection, like is shown here. The patient is laying belly down on the table, right? And the central ray is coming from above. Okay? The patient is, I know, that was horrible. The patient's in the PA projection, okay? You have to rotate this patient 45 degrees in order for that joint space to be pointing straight up towards the central ray, right? Okay, so 45-degree rotation. We're looking from the top right now. So we're standing at the head looking down towards the feet, okay? What position, which one of the oblique positions does the patient need to be rotated into for this left side to be shown? So we're rotating the patient this way, right? This is their left. That's their right. I'll even give you that.
It's the right. It's the right oblique.
Right oblique. and posterior or anterior oblique? They're laying on their belly, face down.
No, anterior.
They're laying on their belly, right? So it's an anterior oblique and it's a right anterior oblique. So you have to roll this patient this way onto their right shoulder, so their right shoulder's down. You have to rotate this body 45 degrees, right, into the right anterior oblique. So this zygapophyseal joint will be rotated into that position, okay? So when you put the patient into RAO, you would demonstrate the left-sided zygapophyseal joint, right? If the patient was, so the patient's PA right now, the patient's in the PA projection. If they were in the AP projection, what position would show that same joint? If RAO does it,
And that LPO.
then LPO will also do it, right? A left posterior oblique will also do it. Here's the thing to remember. In the RAO projection, you're showing the opposite side, right? You're showing the left side. And it would be the up side, right? The right side is rotated closer to the table, their left side rotated up away from the table. So in the anterior oblique positions, you're showing the opposite side, which is the up side, okay? So LAO position, left anterior oblique, would show us the right-sided zygapophyseal joint, a 45, to be specific, a 45 degree of either of those obliques. Show us the opposite side, the upside joint space. Okay. Most of the time we like posterior obliques. In fact, what I'm going to talk to you guys today about are the posterior obliques. But just remember, if a right anterior oblique does something, then the exact opposite does the same thing. Okay? There's a similarity between that position and that position. They show the same thing. They would both show the left side. It's just that in the anterior oblique, you would see the opposite side. Right anterior oblique shows left side, whereas the left posterior oblique will show its same side, the down side. Okay. That now make sense to somebody? Raise your hand if you have a question, please.
I'm
Okay.
just having a hard time like flipping that around in
I
my
know.
head.
It's gonna be a lot of mental practice. And then literally holding vertebrae in your hand, right, and then putting them into those different positions.
I came up with a simple way to figure it. If you make a cross section, 4 corners.
Yeah.
The RAO in the top, and then LPO in the bottom right, and then they're opposites.
Exactly. And I do a similar thing, I think, to what you're doing. In my head, I'm just drawing a straight line between that position and that position, right? And it doesn't matter which one I put them into, I'm going to show that joint space because that straight line runs right through that joint space. The LPO position and the RAO position both draw a straight line through that joint space, okay? Okay. It really does, I mean, practice is good, reading the books is good, but it's going to come down to manipulating this stuff, having it in your hands like that. Anyways, okay. So that's the thing, 45-degree angle shows us our zygapophyseal joints. That means zygapophyseal joints are shown when we oblique the patient, okay? Let's remind back to the cervical spine. In the cervical spine, when do you see, in what position do you see the zygapophyseal joints? AP, oblique, or lateral? Cervical spine. It is the lateral projection, yeah. So the lateral projection of the cervical spine shows you zygapophyseal joints. An oblique projection of about 60 to 70 degrees in the thoracic spine shows you those same joints. And in the lumbar spine, an oblique of about 45 degrees shows you those joints. Okay, we do more obliques of the lumbar spine than we do of the thoracic spine. If you remember last week, the essential projections for thoracic spine did not include the obliques, right? They're in the book, but I didn't give them to you as an essential projection. But the lumbar spine, you'll have them. We need to be able to see the lumbar spine zygapophyseal joints. Okay. The next image is this, so our anterior view. This is the image that we're getting, or something very similar to it when we do the AP projection, okay? So just quickly, in the AP projection, and it doesn't matter if they're AP or PA, both projections are a frontal view, right? Both projections are going to show you the vertebra from what looks like the front, okay? When you look at the vertebra face on like this, you should notice that above the vertebra and below the vertebra hang those articular facets. They extend above and below the vertebra. So you can see those. And you can see that they lie roughly the same position on the vertebra, okay? You can also hopefully infer that if this patient rotates, because these articular facets are in the back, if the patient rotates one direction, these facets, all four, move opposite of their rotation. If they roll towards their left side, then all these facets are going to be shifted to the right, and you can see them shifted left and right on the image that you're looking at, and that'll tell you on the image if the patient has been rotated. It's your goal, as we learned last time, to make sure the patient is not rotated when you have them on the table for these AP projections. What plane of the body for the AP projection, what plane of the body needs to be perpendicular to the table? AP projection. Mid-sagittal plane, right? So the mid-sagittal plane, they're laying on their back, a mid-sagittal plane running a midline down their body, right? That, if they're laying flat on their back, will be perpendicular, straight up and down to the tabletop, okay? So we're, in the AP projection, we're making sure mid-sagittal plane is perpendicular to the table. Okay, also notice, laterally, we have transverse processes easily visualized. What we don't see in this image, we don't see several things, but one important thing we don't see is we don't see, right down the midline, we don't see the spinous process, okay? However, for one, if you take the vertebra and literally just turn it around, an actual vertebra, there you see your spinous process, okay? But on the radiograph you will see this, okay? Because the spinous process is extra density, extra thickness for the beam to travel through, this area, right in the middle of the vertebra where the spinous process is, will show as a white line. Okay, let's take a look at one radiograph real quick.
You won't see an outline of the spinous process, it'll just appear as a straight line.
Well, I mean, you do kind of see an outline of it because it's thicker on the sides, it's thicker laterally. Okay. But here are our spinous processes. Right. Those are all our spinous processes. Now notice they aren't perfectly midline, okay? Each one kind of diverges a little bit, but you can get a rough idea of rotation because those spinous processes should roughly be midline, and if that patient is rotated at all, they're going to shift just like the articular facets will. On the image, they will be shifted either right or left, apparently, to our view. Will be shifted right or left. So these spinous processes here help us determine if we are rotated or not. So we use these bony, not bony landmarks, and we can't touch them. Well, they are bony landmarks, they're just not topographic, you can't touch them. But we use these landmarks on the body to tell if we are, in some cases, rotated or not. So the lumbar spine, AP of the lumbar spine, is the projection where you're going to want to look at those spinous processes. So that's what's in this image is labeled as C.
So on the articular, I can't remember the words. On D&E.
Yeah.
I'm looking at that and I don't see anything.
Okay.
So other than, I know that it's outlined.
Yeah.
So how do I, as I was looking at, I was like, how do I identify it? I don't see anything.
Yeah, I mean.
Other than I know it's supposed to be there.
I mean, you know it's supposed to be there for one. You know where it should be, right?
So what's the philosophy?
So you're looking for the density. You're looking for extra density in that area, and I can see here and here. I can outline the ones above. You might need to maybe be closer like I am, right, or have a larger image like I have. But you're looking for the faint outline of them. Okay. Now it's hard, right, because there's a bunch of overlying stuff, right? This image is not good for viewing those articular facets. We have a special image for it. So we're not, while we can pick them out on the image, we're not using this image to evaluate those structures. Okay? We're using this image to evaluate the vertebrae from the front, the transverse processes. Right? We're looking at these transverse processes. We're looking at overall alignment in this image, but we're definitely not super concerned about those articular facets in the joint they create because they're not well visualized.
Okay, so that's how we come up with the series of.
That's why we have
images.
the other projections,
Because
exactly.
We want to see this part, we want to see the body and
Right.
the spinous process, and then we take the other views to get the other.
Correct. So if I want to see the zygopophyseal joints, I'm going to do an oblique like this. Okay. Where I get to get a much better outline of those joints, of those facets, and see the joint that they create. Right. So we have a special projection just for those. Well, I'm going to cover that in just a minute. I'm getting ahead of myself. Yeah. Okay. It's easy to do. All right, so here is our sacrum. Okay, in a moment we'll look at the coccyx as well with it, but a couple important things about the sacrum. The wings up here of the sacrum are called the sacral ala, which are the same name that are given to the wings of the pelvis, right? The ilium of the pelvis, the big wing part of the ilium of the pelvis, also called the ala of the pelvis, ALA. You'll notice that the sacrum is a series of 5 fused bones. That's why we say when we're a child we've got like 33 vertebral bones, but as an adult only 26. It's partially because this is one of the ones that fuses from 5 into only 1 bone as an adult. These fuse and make an immovable joint. We still have sacral foramina. We still have the holes for peripheral nerves to travel through. Other structural things to be able to point out, the top of the sacrum where L5 sits, creating the L5-S1 joint space, is called the sacral promontory.
I keep seeing that word in particular pop up everywhere.
Yeah.
So I'm using this other app to like kind of do like the practice tests and stuff.
Yeah.
And it teaches you anatomy. But that particular part right there, and it talks a lot more about the anterior portion of that area. So that's really important.
Yes, the sacral promontory is important, primarily because it serves as the base for the entire spine to sit on top of, right? So we want to see the relative position of lumbar vertebra 5 compared to the sacral promontory, that would be the top of the body of the first sacral bone. We just give it its own special name. And then notice the sacrum also has its own articular facets, but only superior articular facets because everything else is now fused. Okay, but we've got our articular facets here for L5 to articulate with. Main part of the sacrum is the sacral body, and the most inferior aspect of the sacrum is called the apex. You also see this name given to the pointy part of other things too. For example, the patella, the bottom, from anatomic position, the bottom of the patella is also called the apex. So apex does not mean it's at the top, it just means it's the pointiest part of whatever the structure is. The sacrum laterally is going to become a little more important. So the lateral projection, or the lateral view we have here on the sacrum, anterior to our right, posterior to our left, we can see what used to be spinous processes, okay, which are now just all collectively fused and called the median sacral crest. We see that our sacral promontory lies at an angle. It doesn't sit flat or horizontal to the floor, parallel to the floor. It lies at an angle. So we want to know that angle, okay, because one of our projections is going to be, we don't need to learn that projection, but it's important that we will learn this angle. It's an angle, and it would be used for a projection. It's just not going to be one of our essential ones. Secondly, the sacral body projects backward. It projects posteriorly, making a curve with the coccyx. What kind of curve is that? A curve that points towards the back of the body.
Okay.
It's either kyphotic or lordotic. Kyphotic, right? The same as the thoracic spine.
Lordotic is when it's pointing forward.
Is
right?
when the curve points forward in the body.
The way I remember that is the lordotic chest, so that body goes forward.
Yeah, I like that. And so, yeah, so we just have these compensating curves in the spine. The sacrum and coccyx happens to be a compensating curve for the lumbar spine, so it curves the opposite direction that the lumbar spine does. This angle that the sacral body sits at relative to the midline of the body is different in different people, different in male, different in female. So we're going to learn that angle today. What I was actually trying to get to when I was talking about this is one of our essential projections is the AP axial of the sacrum and the AP axial of the coccyx. So we'd be coming in from the front here with our central ray, and because this lays at an angle, if we came in with a perpendicular central ray, we would foreshorten our image of the coccyx and sacrum. So we want to make sure we know what angle our central ray has to be at in order to not foreshorten either of these structures. And notice that the sacrum curves that way, where the coccyx curves the opposite direction, right? So we're going to need to know two different central ray angles for the coccyx and the sacrum. Also take note of our articular surfaces, okay? Making the sacroiliac joints with the ilium, either ilium, left and right ilium of the pelvis. And the SI joints are one of our essential projections, so we'll learn this joint space as well. Quick little look at our coccyx. The coccyx is anywhere from 3 to 5 fused bones, okay? And we get the layman's term our tailbone, right? And it's easy to fracture. You see from this image how that it kind of sticks out, sticks down, and that's the tailbone. It's right there, just right there, pretty close to the surface of the skin, and it tends to take on a lot of force when we fall onto our butts. And this can pretty easily fracture. It's a very fragile little bone. What's that? Sitting for too long? I mean, yeah. Have you heard of that happening? Really? Oh yeah, yes, it can hurt. I was thinking fracture, but that would be horrible if you fractured it by sitting. Traumatic sitting injury. Yeah, skateboarding.
45-year-old dad.
You know? But so you see here that the relative size is very small, right? That's a postage stamp, about an inch by an inch, right? And the coccyx is not much larger than that. Here's an image. This is one of the essential projections for the sacrum and coccyx. It's the lateral sacrum coccyx. Most of the time we do things separately. Like if we wanted to get the AP of these bones, we would do them separately because they sit at different angles, right? The sacrum and coccyx make kind of a curve like that, and you have to shoot one image for that sacrum and one image for the coccyx. But laterally, they lie on the same plane. Laterally, they can be both imaged together, so we typically do. It's typically a sacrum coccyx combined image. I will parenthetically say the only thing I don't like about this is we don't include the entire sacrum in this image. So normally the entire sacrum should be included, including the lumbar 5S1 joint space.
Is that just like a rule of thumb, or is that something that's...
No, it's got to be included. Yeah, this is actually not a true image of the sacrum. This is.
You're saying this is in true image because of the example you're giving.
Right.
That image right there?
Right. So you would want to see the L5S1 joint space in every sacrum and every lateral sacrum. Right. You want to see the whole bone in every image of the bone. This is actually not a radiograph. Well, I mean it's technically a radiograph, but it's not like a plain film radiograph. You guys know probably by now that plain film radiographs come out as a rectangular field, right? Notice how this field is a circle, right? This was done with fluoroscopy. This is on fluoroscope for something, a barium enema or something like that. And this happens to be a spot image that they grabbed while they were doing that, and they used it in the textbook, but it's actually not a true plain film radiograph. And you can always tell because of the circular field of view. Okay. So, let's talk a little bit about our positioning considerations, and while I do that, let me go ahead and I'm going to run and grab the copies that I was making and give you guys just a couple quick minutes, and I'll be right back. Oh man, they locked us in. We're going to go walk in the rain.
Not too bad.
honestly, doing these packets was very fun for me. It's like, oh, we're gonna, then we're gonna, and I got to draw, I drew little, little diagrams, like the hand and shit. Like little, it made me very happy.
I found out because it was cold, I put this glove on that I used for, this glove that has, like rubber coating.
Yeah.
And I found out that by using that fucking glove, my handwriting is a lot even more legible. So like now I use that glove for everything.
So it's like, it's not like slipping.
Oh my god, I could have had notes on notes. Yeah.
Oh, do you want this? This is
Yeah,
great.
actually, I want to use that.
This shit is the best. It makes so much more sense, because anything with AO means your chest is down, which is the part I was struggling with.
It's just in my, you know, it's the comprehension in my head, I can't see it, I can't visualize it. Like I have to be in front of it to like, you know, really put it down, and then on top of that, I'm trying to complicate it, because I'm trying to see how it actually looks when
I can't translate words into visual.
Yeah.
I'm a spatial
And I think it's also nice just having them all together and being like, oh, that makes more sense.
Okay, let's just these two numbers. But they're all right there as well. I think that these numbers. Where they're at, if you remember.
The curved part is the chest, and the flat part is the back. It's just easy way.
So it's just just put it on the side for like 149.
But I can't see it.
And give them the whole thing. They got a whole little packet of What's up? It's a paragraph right there.
Did you get the line done at all?
I didn't put a number for that. It's gonna be right there.
It's okay. I'm gonna hang out because
191, 192, 201, 203.
yeah.
Because it all just goes, it's the same thing.
I gotta struggle with it. I gotta because I did that with one of the other sections and I just completely wrong the section. I don't even know what I did. I was like, I don't know what I did. So
If you want, you can get like, I only have like maybe 2 months and a half or something, but I can help you walk through that. It's so much easier. But it's easier to do something. It's easier for me to get the work done faster when I'm like talking about it. So if I have someone to study with and they just give them faster.
yeah, I gotta figure this out. Part of it is
So I'm waiting for another program up there, we decide, if the company does decide to put some students through, I'll be on program and get hopefully girls and girls together to see what we can work with the program.
I was like, doggone, we just need to rewrite this program, this module for it. This does same work as part of it.
There's a lot.
It's a lot of information.
But this is easy, it's very straight. It's harder for you guys, because you guys are doing both the MA and this, so you guys don't have all that background. You don't have all that knowledge.
Exactly it.
So I came in here, like, I've already done MA for 6 years, so I'm already familiar with it. So getting to know it, it's a lot easier to flow with it. But for you guys, it's so much more.
Yeah, I've been doing a lot of hard work. I didn't know exactly what she explained why. I was like, I need to make sure. How do I need to know how to remove the mold? You know, so that kind of stuff. You know,
What'd you say?
the blood pressure. Well, she explained it that when you're out there and in our community of healthcare, a lot of X-ray techs are going up. So they'll hire somebody with an X-ray tech, and then they'll cross you into that work. So when you're downtown, you know, you go down to the cottage, they don't have a lot of These are all.
Did you print out, what you were showing us last week? The, like what the test will have?
Oh, good point. Let me send that to the printer right now.
Or, you know what I'm saying?
Yes, the content specifications, right?